Hello all and welcome to another interesting session where we will learn about a disease that has infiltrated almost every household, a disease that almost all of us know is prevalent but seldom have understood the cause and the pathogenesis behind it. We will be discussing about diabetes mellitus. For the ease of the viewer, I have divided my explanation into three parts. To start off, let us discuss about the basic concepts and the functioning of the glucose in our body. And as always, comments, healthy discussions and questions are most welcome in the comment section below because knowledge shared is wisdom gained. So let's begin. To start off, let us first define what is diabetes mellitus. So diabetes mellitus is a disease in which there is either defects in insulin secretion or defects in insulin action or both, as you can see here. It is the leading cause of end-stage renal disease, adult onset blindness and non-traumatic lower extremity amputations. How do we diagnose diabetes mellitus? Diabetes mellitus can be diagnosed by either measuring the fasting plasma glucose, which will be greater than equal to 126 mg per deciliter. The random plasma glucose when measured will be greater than equal to 200 mg per deciliter. A 2-hour plasma glucose will be greater than equal to 200 mg per deciliter during an oral glucose tolerance test when a loading dose of 75 gram of glucose is mixed with 1 liter of water and which is consumed by the patient and then it is measured. Or the glycated hemoglobin, also called HbA1c level, is greater than equal to 6.5%. Now, it is important to understand what is prediabetes. Prediabetes is also a condition that is usually stated when it precedes the diabetes. Now, prediabetes can be measured when one of the three criteria is fulfilled. Similar to the lines of diabetes, we measure the fasting plasma glucose, which will be between 100 to 125 milligram per deciliter, and this is also called as impaired fasting plasma glucose, IFPG, or the 2-hour plasma glucose, which is measured by the OGTT test as previously discussed, will be between 140 to 199 milligram per deciliter, and the HbA1c or the glycated hemoglobin will be between 5.7 to 6.4%. Diabetes can be classified into two major classifications which are commonly known. One is type 1 diabetes mellitus and the other is type 2 diabetes mellitus. But apart from that, there are other types of diabetes mellitus. The first is genetic defects of beta cell function. Now, genetic defects of beta cell function would lead to one of the major disorders called as MODY or maturity onset diabetes of the young. Now, this maturity onset diabetes of the young is also called as type 5 diabetes mellitus, and it refers to a group of genetic disorders where there are defects in the autosomal dominant genes which would lead to impaired beta cell function or impaired insulin function. So, there is a MODY1, as you can see here, where there is a defect in the HN4 alpha or hepatocyte nuclear factor 4 alpha. There is MODY2 where there is defect of the glucokinase gene. There is MODY3 where there is defect in the hepatocyte nuclear factor 1 alpha, and so on. There is also neonatal diabetes mellitus, maternally inherited diabetes and deafness, defects in the pro-insulin conversion and insulin gene mutation. There are also genetic defects which lead to defective insulin action like type A insulin resistance and lipotrophic diabetes. There are defects in the exocrine pancreas due to chronic pancreatitis, any sort of trauma to the pancreas or pancreatectomy which is done or removal of the pancreas, pancreatic cancer, cystic fibrosis. There are also different sorts of endocrinopathies which will lead to diabetes like acromegaly, Cushing syndrome, hyperthyroidism, pheochromocytoma. Infections like cytomegalovirus, Coxsackie B virus, drugs like glucocorticoids, thyroid hormones, interferon A, thiazides, etc. Genetic syndromes like Down syndrome, Klinefelter's and Turner syndrome will also lead to diabetes mellitus. An important disorder which will lead to diabetes mellitus is gestational diabetes mellitus or impaired sugars that arise during pregnancy, which can be dangerous to the mother and the baby if not treated properly. Now coming to type 1 and type 2 diabetes mellitus, clinically this is usually occurring in childhood, whereas type 2 diabetes mellitus usually occurs in adults. Type 1, there will be normal weight or weight loss which will precede the diagnosis, whereas in type 2 diabetes mellitus, a vast majority of patients are obese. In type 1 diabetes mellitus, there is a progressive decrease of insulin levels, whereas in type 2, there is an increased insulin levels. In type 1, there is circulating islet autoantibodies, which is very important. There are no islet or autoantibodies. In type 1, the diabetic ketoacidosis can develop in the absence of insulin therapy, which is a very common complication, whereas there could be non-keratotic hyperosmolar coma, which is the most severe complication in type 2 diabetes mellitus. Now, genetically, type 1 diabetes mellitus, there is a linkage to the MHC class 2 genes and also polymorphisms in the PTPN22 and CTLA4 genes. In type 2, there are no HLA linkages. Pathogenesis, there is usually dysfunction in the T cell selection. And here there is insulin resistance in the peripheral tissues. More on type 1 and type 2 diabetes mellitus will be discussed in the forthcoming slides. Before we understand how type 1 and type 2 diabetes mellitus manifests in our body, it is important to understand the process of glucose homeostasis or the functioning of glucose in our body. Now, glucose homeostasis is regulated by three interrelated processes. One is glucose production in the liver. The other is glucose uptake and utilization by the peripheral tissues, which is skeletal muscles, and the action of glucagon on glucose uptake and metabolism. Was the previous slide a little bit confusing? Let me break it down for you a little bit further. Let us now understand what happens during a person's fasting and postprandial state. Fasting state is when the person is not consuming any food actively. So during that time, what happens is when there is no food consumed, there is decreased blood glucose level, which will lead to decreased insulin and increased glucagon. That would lead to hepatic gluconeogenesis. That is the process that takes place in the liver. Now that would lead to increased blood glucose level. So the resultant being there is no hypoglycemia. Now what happens in a postprandial state? In a postprandial state, that is when the food is being consumed, just after that there will be increased blood glucose level. There will be just the opposite, increased insulin and decreased glucagon. So there will be increased glucose uptake by the skeletal muscle. So there will be a decreased blood glucose level because glucose uptake has been done by the skeletal muscle. So that will prevent hypoglycemia. This is how our body reacts to increased and decreased blood glucose levels. Now, how is the insulin release regulated during fasting and postprandial state? As we all know, insulin is produced from the beta cells of the pancreatic islet. Now, this insulin is actually a precursor. This is then formed into C-peptide by getting cleaved at the Golgi apparatus. C-peptide is a marker of the beta cell function. That is why there is a decrease in the C-peptide levels during type 1 diabetes mellitus. Why? Because in type 1 diabetes mellitus, as we all saw, there is a decrease in the beta cell function. There is an increase in the C-peptide level during insulin resistant hyperinsulinemia. Now, the most important synthesis for insulin release is glucose. As you can see here, glucose, whenever there is an increase in the blood glucose levels, it gets transported into the beta cell through the GLUT2 receptor. So, GLUT2 receptor facilitates the entry of glucose into the beta cells whenever there is an increase in the blood glucose levels. Now, glucose metabolism always requires ATP. Now, what happens is whenever ATP gets activated, it facilitates the Ca2 plus influx. Now, Ca2 plus influx will then lead to increase in the Ca2 plus levels. Now, that would lead to increase in the insulin levels. So, even though there is increase in the insulin level, there is a stepwise release of insulin. Initially, insulin is stored in preformed granules, and this is called as the first phase of the insulin release. As there is continuous stimulus of the Ca2 plus and the insulin, there is active synthesis. What is the purpose of the K plus channel over here? Now, whenever ATP is facilitated, there will be, as you know, Ca2 plus influx, but then the K plus efflux will also be prevented. There will be no K plus efflux. So, there will be inactivation of the K plus channel protein, and then that would lead to membrane depolarization, which will further allow the influx of the Ca2 plus. It is also important to understand the role of incretins in glucose homeostasis. What are incretins? Incretins are nothing but gut hormones. So, whenever we ingest food, there will be release of incretins, which will usually act by binding to GPCR present on the pancreatic beta cells. The two most important form of incretins are GLP-1 or glucagon like polypeptide 1 and GIP, which is also called as glucose dependent insulinotropic polypeptide. Now, an elevation of this GLP-1 and GIP would lead to what we call as the incretin effect. Now, this will lead to increase in the insulin secretion and decrease in the glucagon secretion. And that will lead to promotion of satiety. These incretins are degraded by this enzyme, which is called as DPP4 enzyme. Now, this DPP4 enzyme is blunted in patients with type 2 diabetes mellitus. Now that we have understood how insulin gets regulated, let us now try to understand the action of insulin. To start with, how does insulin act on a target cell? By now that we have understood that insulin is an anabolic hormone, that is, it is known for its growth promoting effects. Now, insulin, when it enters into a cell, it enters via this insulin receptor. Once insulin enters into the target cell, it will activate the PI3K AKT signaling. AKT is a protein which usually shows its effects through phosphorylation. So it acts on the various proteins as you can see here. Now it acts on the TSC protein wherein AKT inhibits this TSC proteins and that would lead to activation of the mTOR complex. Now this mTOR complex would lead to increase in the protein synthesis. AKT also inhibits the FOXO protein. Now once it does that, it would lead to decrease in the glucose synthesis, and it also inhibits the GSK3 protein, so that will enhance the glycogen synthesis. AKT enhances transport of the GLUT4. As you can see here, it enhances transport of the GLUT4. So there is increase of the glucose uptake. Now on the body, insulin has its action on three major organs. One is adipose tissue, wherein there is increase in glucose uptake, increase in lipogenesis and decrease in lipolysis. Adipose tissue has a part called as a beach adipose tissue. Now this beach adipose tissue gets utilized during exercise and that utilizes maximum amount of glucose. Insulin also acts on the striated muscle wherein there is increase in glucose uptake, increase in glycogen synthesis and decrease in the protein synthesis. Now in the liver there is decrease of the gluconeogenesis, increase in the glycogen synthesis and increase in the lipogenesis. So this was the first part wherein we have discussed about glucose homeostasis and the basic definition, classification and broad differences between type 1 and type 2 diabetes mellitus. In the next two parts, I will be covering about type 1 and type 2 diabetes mellitus and its complications in detail. If you like this video, please like, share and subscribe to my YouTube channel, and I'll see you in the next video. Bye bye.